Thanks, Peter. John and Mort, always a great conference. Thank you for the invitation. And so these are my disclosures. I think it's important to disclose I was assigned the pro position, so everything's not completely deep down in my heart how I believe, but maybe that'll come out in the wash at the end. I also want to disclose that I really consider Nancy Bartlett a friend and a colleague. And hopefully she'll be nice to me. So we talk about these teeter-tots or scales, and of course the goal in Hodgkin lymphoma, where we know the majority of patients are cured, it's not 100%, that is our goal, is maintaining efficacy, if not increasing efficacy, with different levels of efficacy. Of course, cure is the holy grail. Maybe a second level before that is, can we have less progressions or relapse, however you define that? And can we maintain whatever efficacy, maybe cure, with less treatment, while concurrently mitigating toxicity, whether it's acute toxicity during treatment and certainly late effects, as the majority of patients are young. Also, quality of life endpoints are important, although we probably don't have enough of these in Hodgkin's, although some are coming out. And financial toxicity, of course, is important. So I think a one-slide context for this debate is important, and it's hard. You could have a whole hour of context. But when we talk about PFS in Hodgkin's, whether early stage or advanced stage, and we're talking about advanced stage here, we have a multitude of studies that are highlighted in the bottom right that have shown a progression-free survival benefit, and these are the BIACOP studies based out of Germany. And I think it would be fair to say, outside of Germany, these have not been widely adopted. And the question why, I think really due to untoward toxicity. Of course, they haven't translated, we think, into an overall survival benefit, but besides that, pretty significant toxicity, whether cytopenias, infection, AVN, increased slight incidence of acute leukemia, etc. So what has been a semi-standard the last few years, and it's probably you could take a poll on this and get different answers, but at least in the academic world, and I think in many community practices, it's been this Rathel approach, as published in a New England Journal a few years ago. And so this is PET-adapted therapy with a PET scan after the second cycle, and if it's negative, you drop the bleomycin to ABVD. And so what does that do? It deletes the bleomycin after 2 cycles, so 100% of patients receive 2 cycles, or two cycles, 4 doses, in 80% of patients. But by this approach, by the letter of the law, 20% would then change over therapy to BIACOP in some form or version. It should be highlighted that there's not randomized data to say that changing to BIACOP, it's all been historical control, but that has been done. And of course, one caveat to this study that's important is it is only in patients less than 60 years of age. It really should not be given BIACOP in any form, including baseline, to older patients. So this is the study design. I won't spend a lot of time on this. A pretty clean study, I guess you would say, from 1-to-1 randomization of ABVD for 6 cycles. And this was designed before the Rathel, and that's why, in part, there was not a PET-adapted approach, versus the A-squared VD or AAVD. You can see it was advanced stage and other characteristics on the left. There was an end of cycle 2 PET scan, and therapy could be changed for a Deauville 5, so very, very positive, and that did not count critically important, I think, as a PFS event. So to one slide, pros and cons, at least through my lens, of AAVD. So pros, first FDA approval of a targeted therapeutic approach in untreated classical Hodgkin's. Improved modified progression, and I'll talk about that, of course, but also progression-free survival, as has data coming out for all patients. Even greater PFS benefit in certain patient populations, such as all patients treated in North America, as well as other populations. It is all ages, so not just excluded to less than age 60. Of course, significantly less bleo. There is no bleo in this regimen. Are the pros. Cons, there is question of this endpoint of modified progression-free survival. As many and most Hodgkin studies, lack of overall survival benefit. There was more febrile neutropenia and neuropathy, and of course cost. And I'm not going to talk a lot about cost. It is important. I think at the end of the day we want to find the best treatment for patients and let others hopefully help us with cost. So what is this modified progression-free survival? And so at the bottom right really highlights some differences from pure PFS, which really would just be PD, death at any time, as well as some would consider treatment without progression. But it was really for a positive PET scan at the end of the 6th cycle, as you can see at the very bottom right, counted. Now this ended up being a small amount of patients, but nevertheless was there. And so what can we say about that? Why was this chosen? And this comes from the paper and Connors and others of why, is that it was an assessment of treatment effectiveness, as you can see, by scoring additional chemo or radiation due to lack of CR at the end of therapy as an event. And I think it's fair to say that cure is our hopeful expectant outcome for first line, and arguably that this represents curative intent. And, oh, by the way, it was conducted under a special protocol agreement, and the FDA did agree to this endpoint. And I think at the end of the day, a lot of this could have been avoided if they just used a different definition and didn't use this modified progression-free survival, and they called it EFS, or freedom from treatment failure, and which many Hodgkin studies have done, and which in a way it would have fit that. So it would have been somewhat moot if they used, to me, or at least less of discussion point. So what did the data show, and why is it debatable and somewhat of a hot topic, is even though it was statistically significant, as you can see here with the 33% reduction in modified progression, that absolute benefit was 5%. And in terms of the delta improvement of AAVD. And again, now it's hard because you're starting with a 77% benchmark, so it is hard in a disease such as this to show improvement, but the bottom line is it did. And this was per independent review, just to look at other deltas. When looking per investigator, delta was 6.6%. But oh, by the way, when just looking at progression-free survival, so forget about modified progression, it was still significant. And so this is PFS by investigator. What was that delta? So not modified, just PFS. Regular PFS was 6.2%. And this is not including, again, the note at the bottom left, subsequent therapy, not including that as an event. So just highlights that it really was a small minority of patients that fit into that modified progression-free survival. So what about some of the treatment emergent events that I had mentioned? So febrile neutropenia was one, and obviously when the study first started, it was not mandated to have primary prophylaxis. A letter came out, and what you can see is, especially in that middle one, febrile neutropenia, I think what we care more about than neutropenia, is the rate, as you see, went from 21% to 11% once primary prophylaxis was required, or at least encouraged, I should say, and you can see that pretty much then matched the rates of ABVD. What about peripheral neuropathy? You know, we still see peripheral neuropathy with ABVD, right? It certainly was increased. With AAVD, that is something not to minimize in any degree. Now, as you can see in the bottom left, that about 2/3 that this returned to grade 1 or less. I think this will be something critical to follow, and definitely something not to minimize, is again, young patients who are hopefully going to live a long, healthy life. We want to make sure that is followed closely. Of course, interstitial lung disease or pneumonitis, et cetera, was increased in the bleomycin-treated arm, and this is also something not to minimize. I think it's one of the worst events that can happen when someone's cured and they have a morbid and, God forbid, mortal bleomycin-related lung events. And sometimes it can be completely, or I would say most times, completely unpredictable on that. And you see, obviously, that was increased. Just to drill down more on that, in terms of deaths on study, maybe not surprisingly, that 11 of the 13 deaths on ABVD were due to bleomycin, or at least pulmonary-related events, likely bleomycin-related. Interestingly, of the 9 deaths, 7 were due to neutropenia or associated complications. Interestingly, 6 of those 7 without primary growth factor prophylaxis. So when looking at least deaths of patients who received primary growth factor, that was much decreased. I'm not going to go through this in detail, but I think, when we say at least, what else did it get us, or at least relatively speaking, so 33% on the experimental arm received fewer subsequent chemo, and 33% less patients received transplant. And of course, devil is in the details with many of these studies, and I think looking at least by all patients on modified progression by the IRF, what were some groups that seemed to benefit more than others? Stage 4 seemed to benefit more. Extranodal sites, and of course these are all factors that we know, whether in the original Hasse, Cleaver, and Deal or early stage or adverse factors over the years. Interestingly, and this doesn't get talked about, male versus female seem to benefit more. We know males have an adverse prognostic factor. Why is this? You know, there's been older data that males have less of an ANC nadir than women. Is that, you know, did this induce more neutropenia, and that was helpful for male patients? I'll talk about age, really less than 60, over 60 did not appear to benefit. And then really interesting data, you look at the Americas, North America were countries that benefited. Europe, it was trending, and Asia did not, although that was a small number. So what about age? You know, this is online now at JCO. We designed this study about 6-7 years ago, so even before I think Echelon was conceived, and we just rationalized that concurrent therapy would be too much. So we gave sequential therapy to older patients. This was about a 50-patient multi-center study. So untreated older patients, we started with 2 cycles of brentuximab vedotin. We called AVD standard, and then consolidated with a few more doses of brentuximab. And so interestingly, after just 2 doses of brentuximab vedotin, you can see the response rate by PET was 87% with a CR rate of 30. And at least by the end of chemo, before quote-unquote consolidation, that CR rate was 90%. Interestingly, look at the grade 2 peripheral neuropathy. This is the same or a little less, actually, than in the Echelon. Why? We ended up giving half as much brentuximab in this, so there's only 6 total doses, was probably a big part of that, and very few had, thankfully, grade 3. These were the results. So from A, B, C as EFS, PFS, OS. Again, these are older Hodgkin lymphoma patients where you'd expect a 2-year PFS to be around 50%, 60% at best in many studies. So that's age. What about, remember the forest plot of region? So this is very interesting data. I'm not sure we know exactly why. So what was the delta when just looking at North America of patients? And that delta now is 10.6%. And when you look at per investigator, that delta is 12.8%. So that's getting, to me, a little more of a tenable difference. And if you want to talk about a number needed to treat, if we use 12% as that would at least bring it down. Instead of 20 patients to prevent 1 progression, now this would be 8 patients to treat to prevent 1 progression. You know, what is that right delta? What is that right number? I'm not sure, but to me, you know, we do live in North America, so this data would be relevant. And here is PFS, so forget the modified, this is PFS by investigator in the North America, 12%. Why? Again, I think a little bit, could it be that we're a little more aggressive or in terms of dose reductions, et cetera? And it did appear, as you can see, especially in the AAVD arm, at least in America as well, comparatively to Europe, I'm not sure this was statistically significant, but less dose delays. I think there's been an abundance of data over the decades that dose delays for Hodgkin lymphoma, no matter what therapy you're giving, are not recommended and not good, that we want to maintain dose density, at least with cytotoxic chemotherapy. But I can't say this is definitely, and there certainly may be other reasons that need to be fleshed out. Overall survival, hard, probably not going to be achieved in our lifetime. PFS, I still think is important. We could say to what degree. And I think at the end of the day, it comes down to applying this population mountain of data to individual patients. And sorry, Nancy, but I had to apply this to an individual patient of mine. And this was a patient of mine that I did treat recently. And you could argue as a select, what other populations, but she was a young, you can see, single mom, stage 4 disease, had significant risk. And we talked about the options, and at least for her, this is one that I thought made sense in terms of AAVD. So, summary and conclusions. Among the best reported outcomes to date for untreated advanced stage, significantly superior modified and PFS, and if we want to say at least relatively speaking, 23% reduction in risk of progression, death, or need for additional therapy. By investigator, that number is 28%. More benefit in North America, need to understand why, but if you say relative risk reduction of 50%, which is really something significant, and I would say a different toxicity panel. Obviously less lung, you need to use more G-CSF, and the peripheral neuropathy is going to be something to look at. Obviously we want to, as I alluded to, think of quality of life. How does this data translate to community oncology? And of course, cost is something to consider as well. And maybe I'll just say the icing on the debate cake or glaze on the ham, whatever you want to say. And I have permission to show this. So this is going to be our new North American study that will be opening next year. It's a SWOG-led study. All of the adult cooperative groups are participating. Canada is participating. The COG is participating down to age 14. So it's not easy to get everyone to agree. And there's a lot of factors went into this, and I don't want to minimize that. But the standard / backbone will be the echelon 1 backbone. And what will be the experimental arm will be concurrent checkpoint with AVD. This is going to be a large, as you can see, almost 1,000 patient study that is working its way through the NCI as we speak. So I'll just acknowledge my clinical Hodgkin's mentors, colleagues, collaborators, and patients. Thank you.